Dr. Rajeev Jayadevan, Consultant Gastroenterologist from Sunrise, Kochi, to speak to us on colorectal carcinoma. Has the time come for screening?
Sir, please.
Respected chairpersons, senior teachers and friends, I'd like to thank the organizers for the invitation and for choosing this topic. Colorectal cancer has a time come for screening. Here is this patient, late 40s, in your office. The patient is asking a question. Doctor, how can I protect myself from bowel cancer? At least a few of us would respond like this. Do you have any symptoms? Any family history? Are you a vegetarian? Do you eat red meat? If not, don't worry. You won't get bowel cancer. If at least a few doctors respond like this. It's important to know that up to 95% of colorectal cancer is sporadic. So if we continue to check for family history, we're going to miss 95%. And being a vegetarian does not protect against colorectal cancer. A very large study comparing meat eaters and vegetarians was published. It is a cohort study, a very rare kind of study of extremely high quality from Britain. Showed that there was no reduction in colorectal cancer between red meat eaters and vegetarians. So the argument that people in India are primarily vegetarian and are protected against colorectal cancer does not hold true. Most doctors advise colonoscopy for alarm symptoms or red flag symptoms like blood in stool. This is called a diagnostic colonoscopy, but a colonoscopy that's done on people before symptoms is called a screening colonoscopy. Both are done in different situations and with different intentions. It's helpful to remember that colorectal cancer is one of the few genuinely preventable cancers. And as we recall, because of the large caliber of the bowel lumen, it takes a while before the cancer develops symptoms. So often, these people present late. In a series from Tata Hospital, Mumbai, 30% people presented with metastasis. This talk is about screening, and it's important we look at the WHO criteria for cancer screening. The target disease must be serious and common. Effective treatment should be available, and the test procedures must be acceptable, safe, and relatively inexpensive. Colorectal cancer screening is a standard of care in all developed nations. However, in India, screening for colorectal cancer is not done much. One of the reasons is the cultural difference. The Indian patient's mindset is, why have an invasive test if I have no symptoms? There is a view that colorectal cancer is rare in India, and there is a complaint that we don't have the resources. At this point, it is good to know that there are two different types of screening. One is called the opportunistic screening, the slide I presented first. The patient sitting in front of us asking, doctor, what can I do to reduce my risk? And this is doctor-patient interaction, also termed opportunistic screening. The other type of screening is if I were the health minister of the state and I decide that we screen the entire population for a disease, and that is called organized screening. That is typically state funded, requires a lot of monitoring, follow-up, and investment of resource. So opportunistic is what we all do on an everyday basis, and organized is for the policymakers. For most of this discussion, we will be talking opportunistic screening here. In India, we have the following 3 screening modalities: colonoscopy, sigmoidoscopy, and FOB testing. Now, FOB testing, as you know, in a colorectal cancer which is sufficiently large, can bleed in small amounts, and FOB test can pick it up, and if the test is positive, the patient gets referred for a colonoscopy. The others are not of value in this discussion. Because the topic is screening, it's important to remind ourselves of the timeline of screening. Here we have a small bump in the wall, which is called a polyp, which over a course of 10 to 15 years grows into a large tumor. That is called the polyp cancer sequence. Now, if you do an FOB test, we are picking it up at a stage which is just before perhaps the metastatic stage. Whereas if we do a screening colonoscopy, we are picking it up at the size of a small bump. So that is the difference in the 2 kinds of screening. A colonoscopy has a double advantage of A, detecting and removing a polyp, and B, incidentally, if there is cancer, we pick it up at an earlier stage than waiting for symptoms to appear. Just how effective are these strategies? There is proof that screening prevents colorectal cancer, and after several years, proof has emerged that cancer deaths have also been diminished. This is a study of the original National Polyp Group who demonstrated a 53% reduction in deaths. And most developed nations have been publishing graphs like this over a 20-year horizon. You're seeing a decline in not only the incidence but also the mortality. Now let's move to the Indian scenario. The colorectal cancer data in India is misleading for many reasons. One, we don't know the denominator. So if you're not screening normal people, how do you know the denominator? We don't know the numerator because most colorectal cancers, at least half of them at least, are silent, so we don't know the numerator. We only know the ones that end up in the hospital. So most of our information either is from hospital registries or through population screening, which is mostly death registers. Death registers typically mention causes like cardiac arrest and myocardial infarction as cause of death. They will not mention colorectal cancer as a cause of death. The ICMR, Indian Council of Medical Research, has announced that there's a significant increase in the incidence rates of CRC in the big metros, Bangalore, Madras, and Delhi. And why would that be? It's because these people have access to the relevant diagnostic facilities. There is also the phenomenon of gene mixing. Over the past several centuries, many seafarers have arrived from Europe through the Mediterranean Sea, through the Red Sea, across the Gulf, into the Arabian Sea, in search of spices. They landed near Goa, in Gujarat, and then came to Kodingalur or Muziris. And from Muziris, the ships would travel all the way to Calcutta and then around the other side of the world. So over the years, there has been a mixing of the Scandinavian genes in the coastline of India. So many diseases that are typical or considered typical of Scandinavia are in fact found along the coastline of Kerala. That is Muziris. A large series of 800 cases was published by Dr. Shesta and Co. from Tata Memorial Hospital, Mumbai. They found that the average age of colorectal cancer diagnosis was just 47.5 years. I looked up the data on young colorectal cancer in India. These are alarming statistics. Many centers from Assam, Calcutta, Raipur, Vellore, and from Cochin have reported alarmingly high numbers of young colorectal cancer. These are under the age of 40 or under the age of 50. Now you can imagine that there is a bias that it's quite possible that the breadwinning person might have greater access to the hospital. Even allowing for that, I looked at data that is available in Kerala. In my own center, age less than 50, we had 24%. Dr. H. Ramesh from Lakeshore Hospital gave 19%. Binoy contributed 17% from Medical Trust Hospital. Prakash Zacharias contributed 15% from his center. Dr. Rajneesh gave 15% from MIMS Calicut. And Dr. Dinesh from Amrita gave 12%. Now these are the incidences of young colorectal cancer in our part of the world. Now when we are faced with a young patient with colorectal cancer, the obvious question that comes to me, being obsessed with prevention, is when did this patient's polyp first appear? The timeline is clear. If the cancer diagnosis was at 47, the polyp must have happened at 32. But if we screen these people at the age of 50, many of these patients would have missed the bus. When to screen? 35, 40, 45. These are questions that need to be discussed in the oncoming forums over the next few years as more data comes in. It's not the first time that the proposed age of screening was considered lower. This paper from the Journal of American College of Surgeons have said that they need to bring down the age of screening because most of the 50+ cancers incidence has already come down. And it is the 50- ones that's going up. Professor Verghese Thomas, Dr. Ramchandran, Dr. Choni and co. published one of the first papers about the incidence of colon polyps in Kerala. My own series showed, this is from Kochi, showed that there's a significant bump in the incidence of polyps at age 40. And my own series showed that you could reach more than 50% of adenomatous polyps in the rectosigmoid. So if you do a sigmoidoscopy, you can still reach them. That being said, not all colonoscopies are equal. A colonoscopy is not like a pregnancy test. There is very little that can go wrong with a pregnancy test. But in colonoscopy, there's a bunch of things that can go wrong. For instance, there are benchmarks of quality. The adenoma detection rate. How good are you as a gastroenterologist is determined by objective numbers. For instance, in the US, doctors are expected to publish their adenoma detection rates because such doctors are better at detecting cancers. I'll show you my own rates. In the age group 40 to 50 years, I picked up 9%. And age group 50 to 60, it's 18%. And more than 60, it's 16% adenoma detection rate. That's not far behind the US benchmark of 20%. Shows two things. One, my colonoscopy technique is good. Second, that polyps are quite common in this part of the world. Polyp detection rate depends on how thorough you are, and how thorough you are depends A, on the bowel preparation, and B, on how long you spend examining the colon. For the younger gastroenterologists out there, please do start monitoring your own withdrawal time, like I do with my own withdrawal time. This is my own notes. My staff do the monitoring for me. And my most recent withdrawal time is 8 minutes. That is the time taken from the cecum to examine all the way back to the rectum. So that's 8 minutes. 6 is the global standard. So I'll say this, that the entire country being screened is not feasible in India for a variety of reasons. The costs, the per capita income, the limited resource, lack of controlled studies in India, quality variation in performing these procedures, the safety of these tests, and we don't know the true incidence of colorectal cancer in India because we don't know the numerator or the denominator. But opportunistic individual screening is affordable, it is feasible, and there are studies that show that people, especially in this part of the world, they spend about 3,300 rupees every year on healthcare, and much more so in people with chronic conditions. The national average is 1,140. To conclude, colorectal cancer incidence is rising in India. But we are not doing enough for prevention. Waiting for symptoms or changing somebody's diet is the wrong strategy against colorectal cancer. Family history is absent in over 90%. Young onset colorectal cancer is a problem, and adenomas are common over the age of 40. Improve awareness among ourselves, our colleagues in other specialties, and the general public. Thank you.
Thank you, Rajeev, for that wonderful and provocative lecture. Due to lack of time, I can allow one or two quick questions.
Yes. Yes. Yeah, FOB, I do not recommend FOB even though it is a cheap and proven to be effective.